Okay, I just wanted to hit the record. So, what I'm going to talk about tonight is I'm going to talk about some case studies, and nothing really in particular about these case studies. It's just that they were new patients. These three people were part of my new patient group this past week. Okay, maybe somebody from last week. I don't know, but pretty much this week to last week. Um, and they're all cool patients. They have some significant trauma to them where they've come in and they're broken down, and they said things to me like, you know, they told me I need surgery and I don't want surgery. That was like the first statement. Okay, so these people have been in trouble for a long time, and which is kind of like the people that we see anyway in this group. That's the people that we see. That's the people that kind of uh, the specialty of not just Tensegral chiropractic, but upper cervical chiropractic that I did before. So the point of me even bringing that up is I see that somebody may be new on here, and if that is true, some of the things that I'm going to speak about are not the foundation and the sticks and bricks of what we do. I'm going to talk in a flow pattern of and just have a conversation with you guys about what's going on in posture, okay? Because that's really what we're supposed to be doing. I'm trying to figure out how. Here we go. Is that it? Okay. Sorry about that. Okay. So if if you just have joined us, can you put your mute on, please? Can everybody put their mute on? Thank you. Awesome. And just unmute yourself if you have a question. So let me tell you a little bit about Brett. He was referred in. That's the way my practice runs. It's a referral-based practice. Um, and this guy came in and he's got this horrible T1 spinous pain. He's 58 years old. It's severe. It's chronic. It's daily. It's constant. It started, he said, at least 10 years ago. And recently it's gone into his right scapula, and now he's got down his arm median nerve numbness, and it's bilateral, but the majority of it is on the right side. Okay, and he's losing strength in his right arm and his hand. Okay, he's been to two different medical doctors, and they both have recommended surgery, but different types of surgery. One of them had mentioned an artificial disc, and the other one had recommended a disc fusion. Um, he doesn't want to do that, like I said. And two ladies, different ladies, that one lady that referred one lady, and then both of them told them, so they kind of hang out at the yacht club kind of thing. It's that group. And the only thing that's helped him in the past 6 months, when it's gotten really in big trouble, is this diclofenac gel. It helped until about 2, 3 weeks ago, and now it doesn't help either. Okay. So I take standing, frontal, and sagittal films, and through these three cases, I'm not going to show you all those films and that kind of stuff. I just grabbed a couple of films, and I wanted to share them with you so you could get the flavor of what I look at, and which you will certainly do. So take a moment and look at it. And the way that these pictures are oriented is obviously chiropractically is your right side is their right side. You'll see the right marker. Okay. Above that is the listing that I measured on the Posture IQ, which is a device that QSM3 uses that measures digital scales, the weight differential, the configuration of the body. We look at what's low. Why low? Because gravity pushes things down. So you'll see that there's a right low shoulder, and over here there's a right low shoulder. I don't know if that's coming out. Anyway, there's a right low shoulder, and you can see that with the right low shoulder, it's not that the left one is high. Okay, so the shoulder is low because gravity is pushing down on it. Okay, and anything that's low is diminishing the tensegral volume of what the human structure is to be expanded at. Okay, and when it's not expanded, just on a philosophical note, its whole life force energetically. Okay, I mean, because that's what we really, at the end of the day, it's energy. The whole thing is energy. It's not fascia, it's not bone, it's an energetic system, the whole system that's monitored by a nervous system. Okay, but at the end of the day, it's energy. Okay, and that energy sits in a tensegral balloon and it gets compressed. And our life force gets compressed and it shows up at the most primordial, lowest level as guess what? In the physical realm, because the physical realm is the lowest level of existence. Okay. So this hurts, that hurts, and all that kind of stuff. And then people have progressive problems that energetically the whole system breaks down. And we die. Okay. And the soul leaves the bag, man. Okay. So if you look at this thing, this postural listing is saying, what's going on here? So take a moment and you see that there's a right low hip. If you look at what should the upper part of the body do here? Okay. Remember, this is a nervous system. I'm going to ask that you put your mute on, please. Please put your mute on. All right, thank you. All right, so if you look at the bottom, there's been some sort of trauma into that left side. And look at what we're seeing is a human being that's 58 years old, a life of trauma, a life of this, a life of that. This is the cumulative. This is what we're seeing, present moment of all those things his whole life. Okay. So we're going to have a little bit of conversation in a linear way so we could talk about it of this trauma hit here and that trauma hit there and that may be true or not true, but there's a whole lot more to the story than what we're going to talk about as far as his whole life here. Okay, but you, the idea for me is when I first start looking at this is I try to make sense of where is the lowest level of trauma because the human body wants to restore the head on upright. It's a reflex. Okay, so the traumas that are the lowest, you know, and then above that are either more traumas or more compensation. So, with this person, it looks like they've had this shot to the left, from the left into the low lumbars, and you could see how it's kind of shoved the pelvis over into the right frontal plane. The right hip drops. Okay, you can see it around L5 there, that indentation. And then all of a sudden at L2, okay, you see it start bending back. Why is it doing that? Because the muscles on the left-hand side are doing a heck of a job pulling that thing back up to center. That nervous system and that fascial system and his energy system and the donuts that he ate this morning are all cumulatively in an energetic state where it's saying trauma and pulls it up and restores it. And it takes a big tension fascial pull and it pulls the whole body upright. And that's awesome. The problem is there's side effects. We decrease motion. If you have a bend, you have a diminished vertical height, which means you're compressing into the floor. And you can't tell me that when you squeeze a grape, it's healthier than when it's expanding itself and plump. Okay? The human body is no different. So just from the first picture, I get a view of, hey man, look at this trauma here, and look at the way that the body is restoring it. Okay? And then I go and I want to look up top. And I'll say, what's going on there? Because if you were a gambling guy, you would say, hey, you know what? I bet the top is nice and straight and everything is sitting straight. And you look over there and it's not doing that. And the reason why I would even think that it could be doing that is because the lower lumbar on the left-hand side, that tension, those muscles, that nervous system on that side is activating and it's strong enough and it's healthy enough to pull that person upright. So why shouldn't the person be more upright? That's a great question. Why would So if you look at this next picture, something happened, right? Yeah, something happened. So within like 30 seconds, we get to start looking at a global picture of the whole human body. Okay? So that right shoulder is compressing down. That's not the way it should be. Okay? If anything, that left shoulder should probably be turning back the other direction, or at least level. Okay? If you look further up, you see a beautiful little lateral bone spur on that right-hand side. You see a right head tilt. Okay? So, simple question of gravity. Okay? If I take a low hip, a low shoulder, a low neck, and a low head all on the right-hand side, which means they're all squashing down, what's going to happen to that side? Discs are going to compress, and bones are going to start to grow because they're made out of crystal. So there's that bone spur sitting right on that right-hand side. Okay? So this guy's got trouble on the right-hand side is his primary problem. Okay? But he's got that severe pain around, I think it was T1, it was. Okay. So if we look further on down into the last picture, okay, you see the way the whole thing sits together. And what I like to do with this picture is, and one of my favorite things to do with this picture, is just try to see how one vector, one trauma would go into this thing and create this kind of picture like this. You know? Because if you could picture that vector, I can picture the pathway out. I like to look at that way. I like to look at pieces and parts. I like to look at the biomechanics. I like to say, okay, what's not responding correctly? What's normal? What's non-normal? And then we're going to talk about some other things, but these are just the pictures. And then just looking at the flow of the whole thing, because that picture of what you have is homeostasis, which means it's picture perfect of what that nervous system can do right there at 100%. So I can't do better than that. I just need to notice what's going on here. So this way that this thing is holding it, way it's been traumatized, way it's compensating, way that gravity is affecting it, okay, is a path in and a path out for me. Okay, so just look at that and just try to get an idea of how that thing has come in. And then you can start looking at down the road when you go to apply it, is where are you going to put your piezoform to pop that thing out along that vector. Okay. I don't know if anybody else noticed this, but if you look at the left shoulder on the full spine view, look at that trap, how it inserts, where it comes up over to the rib there, and then you'll see behind it is the scapula. You see how much bigger that muscle is? You see it on the A to P cervical thoracic, but the line's in the way of it. So it does impede a bit of the view. But look at the left musculature, even on the neck, on that lower side of C7 and T1, how that bulges out. Why is it doing that? Because those muscles are trying to hold that head and neck up, and that shoulder, and that rib cage, okay? And that low hip, all the way down to the pelvis. Everything is contracting on that left-hand side, trying to hold that thing from falling over. Okay? And how's it doing? How's it doing that? Look at the posture IQ numbers. How's it doing it? Brett, how's it doing?
Right shoulder.
Well, how's it doing it? Is it holding it up beautifully? Is that a good configuration? Are those good numbers?
No, you have a rotation 6 on the shoulders and 18 on the hips, but no, they're not. It's not doing a good job.
No, it's not. I wouldn't even say that. It's doing a horrible job, isn't it?
Right.
It's horrible. Yeah, these are horrible numbers, man. Right?
Yeah, posterior 18 is awful.
It's off the chain. Yeah, and then
Off
put
the
an
chain.
anterior 6. Who's that? Oh, that's Dennis?
Yes, sir.
Way to go, Dennis. Okay.
Yeah, and you're not coplanar.
Yeah, that's well, that creates a counter twist of 24 there, you know. But we're gonna talk about what's going on in this one in just biomechanics world. That's what we're gonna do with this case here. Okay. So if you look at this pattern, what does it even resemble that it could be as far as a normal pattern?
Left, 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 right, right, right.
Yeah, maybe. I mean, that's the one that I definitely would look at it and say that, even though I don't see pelvises move like that. I don't see them switch sides like that. That's not common, you know. So, you know, that does throw a little bit of a red flag into it, okay? But Brad, what happens if you just change the spine and you made that a right?
Then you'd have to have everything on the others on the neurology compensation side switch.
Yeah, but that's the other pattern. No, you would not. Everything would be right and the weight would be left. That's the pattern. That's the second normal pattern.
Okay.
Yes?
You're saying right, right, and
With a
left,
left
right, and then
weight.
right, right, right. So 5 right, 7
Everything
left.
right except the weight? Yeah, that's a wedge between the femur head and everything else, where the femur head goes out to the left, and then the hip, the spine, the neck, head, and neck all are coplanar and counterbalance it.
Okay.
Okay,
Hey,
so
Russell,
yes, sir.
you said you don't see the pelvis switch. What do you mean by that?
Meaning you have a right pelvis here.
Mm-hmm.
Okay, so I like to, I just like to look at stuff and say what's going on here. And there's just lots of little things that go through my mind that have come along in this journey that I've been on. Okay, and one of those things is what is normal. Okay, so we have normal where perfect is the frontal plane's a pencil and the sagittal plane has three curves and this sits over that and boom, 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 everybody's happy. But what's normal trauma? So there are two normal trauma patterns, okay? There is a trauma pattern where it goes left, 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 and the above goes right, right, right. That's the first one that I saw. But there is another normal trauma pattern that I talked about at the class, that webinar class, and also before that, is that there is a pattern where the trauma is at the femur head or in the legs. And in this case, you could have a trauma. Look at that person's pelvis. Okay, look at the femur head in the first picture, the small one, and push from the right side into the left side into the femur head, and you'll see the pelvis will swing out and the right hip will drop, just like that.
Correct.
Okay, right. So the legs move out to the left. That's where the weight is, and then everything else above compensates. And it's a one wedge system, and at 3 pounds and 3 millimeters, it's a very normal, healthy pattern. And I see that actually more than the other pattern. So there's two patterns here, and what I said is I don't generally see pelvises switch sides. So a right pelvis, I generally would not see a right low pelvis hip switch to a left low hip.
Gotcha.
Okay.
Gotcha.
So the other way to look at this is if I just change the left spine, okay, to a right spine, that would be the other normal pattern, okay? And that's important, okay? It's important because down the road, you want to find out where that primary lateral weakness is or where that guy is, which is the guy that is creating the problem, okay? And we're going to get to that in just a moment, okay? But that's an indicator right there that it may be the right hip, like Brad says, but it could also be that left spine, okay? Two very good patterns, okay, that could say that, okay? The next question is what's deviating, okay? And well, we already said what's deviating once we looked at the pattern, and it's either the hip if it's the pattern 1 or if it's the spine if it's pattern 2, okay? And the next question then becomes, where is the wedge here? Okay, where are the wedges? Okay, so the wedges, you just start from the bottom. Okay, so you basically have the to me with this one, if I drop my right low hip and I bring my spine over too far to the left, I can create left weight that way. Okay, I could also, with that right low hip, I could swing my legs out into the left frontal plane. Okay, and again, you may not be able to see this as well because I'm doing this as in a webinar, but I'm going to try to draw a picture and see if you can get some help here. So, bingo. Okay. So if I had a trauma through here, can you see that?
Yes.
Anybody there?
That little black line?
Oh, good. You hear me? Okay, I just
Yes.
lost it for a moment.
Yeah.
Yeah, I made a little black arrow there. So if you had the original trauma goes through there, the hip would drop down on the right, but the weight would swing out to the left because the legs are on the left-hand side. Okay, that is a possibility. All right. So look. For some reason, you guys hear me?
Yes.
Hello?
Yes.
Okay, good. All right, I'm sorry. I get a little signal that says that I lost the connection from WebEx, so I apologize. And all right, so where are the wedges here? Okay, you got a wedge here. Okay, you may have a wedge between the weight, the legs, and the pelvis. Okay, all right, and you also have, because the spine is left but the shoulders are right, you have a wedge here. Okay, so you got a lot of activity going on. You got at least two wedges, possibly three. Okay, so and you can only have three as far as I see it. Okay, as far as the postural muscles go. All right. All right. So let's look at some possible red flags of where there are problems. Okay. So let me erase this. So let's just look at the numbers for a second and tell me what you see as far as where there is a possible lateral weakness. Well, we already talked about it. It's going to be that left spine. Okay. If you look at the picture, could you see that the left spine is failing compared, that the left spine is, even in the picture, it doesn't look like it's failing. When I say the left spine, I mean the spine is failing into the left frontal plane. Can you see that?
The whole thing is curving to the left.
Yeah, you see that bend that goes through that? Yeah. Boom, right through there. Yes? Do you see that arrow?
Yes.
Thank you. Okay, so that's the way I see it, and I see a force that could be coming down when I talk to you about the flow of this thing. Is I could see a force. I don't think I could draw on the X-ray, but I see a force coming down in through like this. Trying to draw an arrow here, sorry. Like that. Coming down into that right shoulder and buckling that upper thoracic spine into the left frontal plane. Do you see that?
You mean you see a trauma coming that way?
Yeah.
Yes.
Yeah. Do you see? Listen, if this person had a big trauma going right down across that right shoulder, right into that that upper thoracic spine, that midpoint. What is that? Probably around T10 there. Okay, T11. You could see a force going through that right shoulder. The head and neck buckles to the right. The shoulder buckles down into the right, and it buckles that spine right through that spot right there. You see that?
Yes.
Yeah. Okay, because that's what I see. All right. So, it's great if you see that. We want to see how the human behaves, but it's nice to look at these numbers and try to see what's going on. Okay, one other piece as far as a red flag, okay, where there may be a problem, okay, for this person is where is it in the rotation? We already talked about it. Posterior 18, okay, is telling you something is really problematic, and that's telling you that something down in the pelvis. Okay, that pelvis is failing. And that pelvis could be failing from that same force as that force drives that down, and that pelvis is just all smashed up down there too, because everything is buckling. And that's what we see down below, is the opposite bow in that thing, right? Yeah. So what would the algorithm be to adjust this?
Left.
Right, left. That's right. Okay, and if we want to get a little more specific, we could say, and this is the way I've been writing it, is right, PA, C0 slash, and then I would write it next to it, but I'm using my pad here, sorry. And then I would put LAP C7. That's pretty much the way I write everything now. Okay? If it's one rotation, it's A or P. Okay? No big deal. Okay. All right. So that's the way I write the algorithm. Moving right along. Okay. So that's what I do here. Okay? And the next step, and we had a nice little conversation of some weaknesses, some flow, where there's damage, where the rotation components are, what the deviations could be from normal, okay, the lateral weakness, where there's rotational weakness and breaking down, okay, how the force could be coming through, what's the in, what's the out, what are the wedges, what is the release sequence as far as the algorithm, and then we're going to lay this person down. And the interesting thing and the cool thing that I find probably one of the most fascinating things that I have learned is the fact that this thing is a balloon, and it's not something that you just push like a building and it falls over and it all moves in one direction. You push a table, it all moves in one direction. Well, that's not what a balloon does. Okay? So you can push into a balloon and forces all come to you, okay? Not to get too involved with that model, but it behaves very differently. And the big importance of it is depending on where you push in the neck is what you are able to move in multiple different directions. So when I push into this thing, okay, of course I everything changes. In an elastic system and in a linear system like a building, okay, everything gets moved. Everything feels the force, okay? Everything, the force transmits through all of it, okay? It is received by all, but the direction at which it moves is different. In an elastic system, you can have things that when you push in, you can have things going right and go left also. And why is that important? Okay, because that because we have, if you look at the posture listing, we got things on the left and we got things on the right. So when we adjust somebody on each side, we want to support that. And we want the things that are left to be moving towards the right, and the things that are right to be moving towards the left. And that is the beauty of the cervicals, okay? And besides that, the cervicals are multi-rotational and dimensional, okay? And it also has a nice little span to it, and you can get in there. So you can dig in and move things around and expand stuff. It's also at the top. It's got lots of stuff. Of course it does. It's 100% perfect, okay, by design for us to do what we're supposed to do, okay? So there's lots of chiropractors that look at C1, okay? I'm telling you C7 is more important, okay? And I'm not telling you it's important like 80-20. I'm telling you you need both, okay? But it's as important. You can't finish the job, okay, without C7. And then you can't finish the job without C0 through C7. And what do I mean by that? Is, okay, this person back on this picture is standing up and is only able to stand up because the nervous system is activating in an unbelievable way that this whole thing is otherwise it'll fall over. And it's orchestrating it, and this person over time feels the tension and all that other stuff from it, but for the most part, it maintains its ability to stand upright and move, okay, for amazing amounts of time, okay, without even telling you, all right? But that lock three-dimensionally from the pelvis and the legs all the way up to the head is what we have to overcome. The whole thing, okay? And the way we do that is by feeling three-dimensional motion up in the whole neck. So if the whole neck is moving, I'm telling you, it's connected to everything. It's all moving, okay? So the idea is not to just poke a point and create a stimulus. The idea is to free the whole thing from the neurologic lock, okay? So you got to understand the biomechanics of normal, and then the problems that deviate from it, and then where the weaknesses are, and then the application in here of where you need to touch that activate the right lines and the right neurology to release it three-dimensionally. And then you have to be able to do it. It's freaking hard. It's hard. Yeah, it's hard. And then it's simple. Different bend points, the way that we go into the neck. And on this one, on the right side up, C0 is the bend point. That doesn't mean that C0 is the only, sorry, I made an error. Here we go. Good. I'm so happy I got it out of the way. Excellent. So on the right side up, C0 is my bend point, but that does not mean that I just touch C0. It means that I drive and I release I to S all the way up to C0. And then above C0, C1, I do S to I. And why do I do that? Because this misalignment, without getting involved with the details of it, because that's not the purpose of this class, is to release things right and left and have everything moving in one direction to tensegral volume, is expanding everything. I'm not looking to move it. I'm looking to release it and restore its tensegral volume, and then create three-dimensional motion and restore that. Okay, on the left side, it's C7. C5 is the support staff, the support that ties in C1 and C7. And then the lines of drive at these bend points, I to S to the bend point, S to I above it, below it. I to S below, S to I above. Okay. Questions? Great. Okay, so I think this is the last slide on this one.
Russell.
So, yes, yeah.
So can you go back to that one real quick?
Sure.
Not sure.
The hunt?
Yeah.
The hunt?
What's going on?
The hunt?
I know. So the right.
All right, go ahead.
Typically, so I think you explained it, but I might have just missed it. And is it because of the line of drive? Typically, whenever I've got a right, on that right, when the right side is up, I'm going to be going I to S most of the way, and not driving that arrow, not going down once I get above C over O, just because that's going to be bending that head back upright, as opposed to. But can you explain why you're going down on that one, where I would think that would kind of pivot the head back up and make it go right again?
Yeah. I'm going to tell you that you're going to start doing that, and your results will change dramatically.
You mean they'll start getting better than what I'm already getting?
Better. You're already at 100%. You're going to get 110%.
Beautiful. All right.
Okay. For now, of course.
Yeah. I mean,
okay. So hold on. Let me explain.
Explanation. Yeah, that'd be great.
Okay. Okay. So first of all, in every system of elasticity, okay, it's like a tug of war. There's got to be one on something, a tension on the other side and a compression on the other side, and they're in balance, okay, some way. All right, fair enough.
Sure.
It's not a matter of just releasing one side. You release both sides, Matt.
Right. Sure.
Okay, and sometimes you have to release the opposite side before the other side will calm down because it's a nervous system. So the greatest power that you have is not your forearms and your biceps, okay? And your mass and your table. It's you and all those things rolling that head downward and around and using it like a big cue ball or it's called angular momentum. It's like 10 times more powerful than a crowbar. So you are able to unlock the neurologic lock so much greater using their head and rolling it, and that move coming S to I is probably I do that at least half the time. Is rolling that head.
Okay, cool. I'll check it out. Thanks.
Yoshi and I, it's lock it. I mean Yoshi's on. We Yoshi and I, you have to lock it to its lowest point and then roll it further.
So are you doing that at the end or or is that like the first touch?
To where? Up there?
Yeah.
No, I don't usually start up there. I usually start at C7 because it's mushy there. I grab something, and I just like to check in. I'm
Okay.
more in the C7, C6, C5 meaty area. You gotta be connected to start rolling the head. Okay.
Yep.
And
Okay.
then once you roll that head, then you can clear the suboccipital triangle, and that's their brainstem there. And that's when they get up and they go woo. Their eyeballs pop open when you clear that fascia there. So I'm sure you are coming to the August class at my office, and that there's a very small group, and it's like a mod 1, 2, and 3, and it's such an amazing thing. This is where I'll be able to teach you that and show you that in an application point of view, not in a lecture format, like
Sure.
like Seattle will be. So hopefully
Sounds
you'll be
good.
there.
Yeah,
Okay.
I'm looking forward to it.
Okay. All right. So this right here is, I really thought this whole thing was going to last an hour. I'm going to try to get it to an hour or so, but this is what I did on this guy. Okay. So on the first day, I did that algorithm, and that was his post, and I was super happy. Okay, super super happy. And the actually, hold on a second. Yeah, there we go. All right, I think that's right. On the second go, this is where he came in. He didn't come in at 65. I got lots of nice typos. I did this morning. Okay, so he came in. His weight was from 6 to 3. That means nothing to me. Okay, pattern didn't change, and his rotation in his pelvis came down. It only popped out to a 12. That's about 30%. So I'm okay with that. That's what happened. Okay, and then when I adjusted him this time, my goal was to switch it up. Okay, I usually adjust not usually. On the first visit, I adjust the algorithm. On the second visit, I adjust what Russell thinks it should do. Okay, and that's what I decided is all his compression is over on that right hand side. I'm going to try to open that right hand side as much as possible. The hip is low. It's an 18. To me, it's maximum failure. Okay, it's showing me that right now, and just go up and just lift that whole thing right side up. And this is what I got on that post. Okay, no big difference. I mean, I wouldn't go, oh, the first one better than the second one, personally. I mean, even because of 1 and 7, I could care less about that. Okay, I'm looking at the rotation. Okay, I'm looking at the rotation. All right, so then when he came back, and look at his oh shoot, I'm a ding dong. Okay. I could do chiropractic, but I actually can't type. It's okay. Can't have everything. So this right here, he came back in. So how would you say he's an anterior 15 and a posterior 16? How would you say that goes?
That's not good.
That's no bueno, right? So I'm not going to go do that number 2 again. I'm not going to do that. I'm going to give him that left side. So what do you think I learned from that? I learned from that conversation that we had, that he needs that left side support, even though he's compressing on that right side. And look at that neck bending into that right frontal plane and the shoulder, man. It's horrible. Look at that neck, man. Okay? I mean, it's crazy. So I learned that this person in their release needs me to get that left side from the left side. Okay? So at least that's what I think for now. So I adjusted them left side up, okay, and then right side up and then left side up, okay, and this is what he posted at, okay, but this felt good when I did this time. The first time it didn't feel, it felt good, but not as good. The second time did not feel, when I did the right side only, it did not feel as good, okay, and the third time felt as good as the first time, if not better. I felt it really separating. So we'll see what happens. Okay. I told him he needs 16 weeks of care of once a week adjusting. Okay. And then he'll also see Allie and Sean for 16 weeks. They may adjust him. Okay. Not me, but they'll also do their functional neurology and the Graston work on to work the fascia. But he paid for his care plan in full. He feels after the first and third visit 80% better. Bingo. Okay. So, all right. Any questions on that? All right, let's talk about Mr. Fraser. All right. So, Mr. Fraser, we're going to have a little bit of a different conversation. Okay. He just came into my office 3 days in a row. He's from North Carolina. He came in Monday, Tuesday, Wednesday of this past week. Okay. He's got severe right arm, forearm pain associated with 1 to 3, the first 3 fingers, paresthesia, weakness in the arm. You could see it's visibly inflamed. He's got diminished strength, and he can't sleep from the pain. Hasn't slept. Okay. He's on gabapentin, one of the most amazing drugs on the planet. It's horrible stuff. Okay. If you need it, I'm sure it's great, but it's horrible stuff for the human soul. Okay. He's got only surgical recommendations. I have a patient of mine that used to be a patient that lives in Florida now that is friends with him, and he got referred to the office and he came in. Okay. Here is his MRI report, okay, that I asked for. I got it on the 3rd day, and I just circled at the top. He's got lymphoma. He had lymphoma, T1, and the new scan shows there's no new activity, and it shows that C4, C5, C6, severe right neuroforaminal narrowing, and moderate on the left, but severe on the right. Okay. You can see from the lateral, he's got actually a crack, looks like a compression fracture in C5. You can see how compressed the discs are in that area, and the spondylo, the Brake and George's line there between 3 and 4. You can see on the next picture the huge right low shoulder and the neck bending, and then the head bending back. The shoulder, neck, and head are not made to oppose each other. So when you see misalignments where they're zigzagging like this, I mean, even worse than this, where they would have a left low shoulder, a right neck, and a head, big, big trouble. And they're very difficult. You can make people feel better, but it's very difficult to change that configuration. Okay. So my purpose is to, just try to figure out what's going on with this guy. Okay. So look at his full spine and try to put it together. He's another one, right low hip. Okay. Right low shoulder. Okay. Only his twist is where in the posture listing? It's up in the shoulder area. Everything's going to the right. None of his posture muscles, which is shoulder down, are able to hold him up. He's leaning too far. He's leaning right 10 pounds. Okay. Nothing is turning back left posturally. And the only thing that's turning back is his poor head with the righting reflex just to get the eyes balanced. The whole left side is under a severe amount of stress. The left side is in failure. Okay, you could see the increased muscle on the left-hand side. See, he's got a shunt in for the lymphoma. He ain't in great shape. He's barely got a tooth there. In all kinds of trouble. Okay. So, I look at this thing and I go, okay, what do I need? What do I got to do here? Okay. And when you got everything, here on the right, who in their right mind would adjust them on the left? Okay. Well, I would. Okay. Because I want to find out what his body needs. And you could see he's also got a rickety little bend over there. You could see almost from like his mid ribs up to his head, how everything is just caving in. Do you see it? It just looks like energetically, it's like a building collapsing. Head, neck, shoulders, and you could see the compression in the vertebra. I could feel it. Okay. So I like to look at these things and say, what is the left going to do for me here? What is the right going to do for me here? So forth and so on. And again, even though I adjust somebody on the left, doesn't mean that I'm just releasing left things. I'm releasing everything. And the way that I go into the neck is that I can be taking out from the left side all these right structures here and moving them up towards tensegral volume and into the left frontal plane. Okay? So it's not a conversation of push the bone, okay? Even though we're talking a little bit like that, all right? Just making sure we're clear. So what is the right release going to do, okay? What about just adjusting him only on the right? I think about that and I said, should I break the protocol today? He's in town for 3 days. He's one of those people that I say, come in for 3 days, and then I'll tell him to go away. And depending on how far away they are, I'll tell him 2 weeks or a month, okay? So I adjusted him, okay? And I just said, okay, I'm going to follow the protocol, okay? So when I adjusted him on the left side, this is what happened. That's the post. I adjusted him on the left side. He went to left weight. The rotation went down more than half in the shoulder. Who thinks that's significant?
That's a good start.
Yes.
Yeah, it's a great start. Yeah. So and it tells me I need to adjust him on the left side. He needs the left side. Okay. He needs the left side. I just learned that he needs the left side. Okay, because it took out half of that shoulder rotation. Okay, and it moved at me, which means either the left side allows that to spring up, that's the path in and out, okay, or I'm going to go get the rest of it from the right side. I mean, that's what I'm going to go do now, okay? And then when I adjusted him, I don't have the post here, sorry. All right, so this is what happened on the second day. This is where it came back. Okay, so he came back from a 15, okay, down to an 8. His weight was right 10, and it was left 4, okay. And the configuration kind of stayed the same, except the weight shifted into the opposite side. Okay, so here comes the conundrum. Do you adjust it on the right, okay, and then the left, because that would be the algorithm for this. Do you follow the new algorithm, or do you follow the old one? And the thing that I found more frequently, I'm not going to tell you 100% because I don't know that, okay? I don't know if it's 100%, but it was more than usual. Which one do you think worked better? What have you guys noticed, or have you?
With what worked the first time.
Yeah, the first one's the guy, and the first one is the one that actually got that rotation out. And there's one thing I care about, and that's rotation. Okay, first. Okay, and I can't have it that way sometimes. Sometimes it comes to center, and I go back in, and the rotation doesn't budge. It just means maybe it hasn't let go, and I got to let it go for the day. Anyway, I did the same thing. This is what happened. Okay. So by the way, this guy, he slept after the first adjustment through the night. No drugs. He didn't take any drugs, and he slept. Okay, I spoke to him today, and today's Thursday, and he came in Monday. He slept through the night. He is about 80% out of pain. The numbness hasn't changed. Maybe the inflammation has changed just a pinch. Motor weakness has not changed, and I don't expect those things to change today. But he can sleep, and he's happy, man, and he's not in pain that he was in. He's down 80%. Okay, so I stayed with it 3 days in a row. Okay, and guess what happens? That big right compression is expanding, diminishing in the rotation, coming nice and together. One big happy family. Just leaning out and opening up into that left side. Okay, so if that left is weak, though, okay, it may be this is the short-term solution, okay? But the long-term stability may be then to change the algorithm and open it on the right and then support it back to center on the left. Mod 3 people, okay? Symptom first. Got to put the fire out. Got to put the fire out. Okay, now I don't go in to adjust symptoms. I go in to adjust the whole thing using the algorithm. And then if something's not working, I'm going after the symptom, where I think is affecting the symptom. Okay, because I got to get some time to figure it out. And that's all they care about. I'm feeling better. They don't care what you do after that. Okay, so, and that's part of the learning of it. Okay, so short term on this guy, it looks like the right side's got to be opened. Okay, and leave it laying out open because the rotations are out. But it looks like it's going to start leaning out to the left. Okay. All right. Case number 3. So this is a guy that just came in. I think he started about 2 weeks last week. Okay. And the reason I put him up is because of the conversation that I just had is to just go after the symptom. Okay. So he came in. He's got right-sided to posterior neck stiffness. It's chronic. Okay, he can't move his neck. It's going on for decades. The guy's in his probably early 50s, late 40s. Okay, it's not just stiff now. He's now, for the past 6 weeks, he's got bilateral QL pain. Okay, and this is his pattern right here. So, the first thing I like to look at is, what's the dysfunction? So if something's dysfunctioning, the only way you know if it's dysfunctioning is you got to know what the normal it could behave like. So that's why we have that little normal conversation. Okay, and then you go from there and you go, okay, what are the numbers telling me? What's the configuration telling me? Okay, how many wedges does this thing have? Where is it stressing? Okay, why does he have the right-sided pain? And if he has right-sided pain there, is it tension or is it compression? What you say?
It's compression.
Yeah, it
It's
is.
cervical.
Well, the
Cervical area.
neck. The neck.
Because the head's buckling to the right.
You saw him. His neck is visibly sideways left. I mean, it's off. It's unbelievable. It's one of these people that you go, how is that tilting that far? And the head bends back equally as far. It does not look as much as the neck in this picture does not look as much as it does in real time. But you see how tilted that head is, right? So he's got this big, this tension on this left side from the neck to the trap, okay? Because you got a left low shoulder and a left neck, okay? So that right side, okay, is in tension, okay, on the neck. But the head is causing a whole lot of trouble. So it's like, it's like you're trying to hold something up and then you have somebody jumping on your back while you're doing it. And he's obviously in failure. Okay. Been going on for decades. Just an interesting way to look at it. Okay. So he's gone through 5 office visits. His low back pain went gone immediately. The neck pain he had a little bit of neck pain, but the stiffness, it's hard to tell if anything has changed. I don't believe it has. He's very low. Yeah, the neck is stiff. And that's really that he tells me. So he's just down in the dumps about it. So I drew this stick figure just a little bit for you, and we'll take a look at it. But this is what I did on the first 3 visits. Is I basically on the first visit I did an LR, okay, and then on the 3rd visit I had to go back in and I had to go and get that RP. I just went back in and it still had weight on the left and I didn't get the rotation out, so I missed something. So I went back in and I went through like an RP vector, okay, to release that with the right side up, obviously, okay. On the 4th time, I said, you know what? I'm just going to do the right side, okay. And it's been feeling good to me. I mean, I have felt good about what I've done, Okay, I don't have the post here, but I have felt good. I mean, when I say that, I feel good separation, and just like, I mean, you could feel it separate. I feel I know when I do a good job, okay, which means I also know when I do a lousy one, okay. So I said, okay, on the 4th visit, I'm going to do just the right side, and he came in and he said, no, my neck is still stiff, okay. And what do you think I do on the inside? I'm like, frick, man. All right, so Russell's got to look in. Okay, so I lean in as I just did. Okay, and I went back and I started looking at his X-ray and looking at his posture and say, all right. What I've been doing is trying to get that on that right side. I'm getting that weight out of there and I'm getting that head out of there. And I'm like, okay, that should be doing a good job. And I said, well, obviously it's something on the left. Okay. I'm going to go after something on the left. And I'm saying, how can I look at it in a way that the thing is failing on the left side and it needs me to support that today because that's where the fire is. That's not where the long-term stability may be. That may not be where vertical is, but that is where this guy can get some relief. And I got to make some positive changes there. And believe me, making symptomatic changes when you're looking at it in a structural way also means you're making structural changes, okay? And they both have to be beneficial. You can't just the guy can't keep coming in and go, it's not holding, but you're feeling better either, okay? But I'm saying, all right, I got to give this guy some relief. Otherwise, I'm not going to have the ability to take care of him, okay? I mean, nobody's going to keep coming back. Okay. So it just kind of dawned on me, and I'm saying, that freaking head is just crazy. Okay. And maybe I just got to support that left neck, and that head is counterbalancing for that left neck. And maybe it's not really just counterbalancing for that left neck. Maybe it's counterbalancing for that left shoulder. And maybe it's not counterbalancing for that left neck and left shoulder. It's also counterbalancing for that left fixed point and that spine breaking off in the left frontal plane. So then I can release him on the left-hand side, okay, last, okay, which means I could do the right first, okay. That's not what I chose to do. I just supported the left side, okay. And this was his post, and it was by far his best post that I've had with him, okay. And the interesting thing about that post was that he stayed on the right-hand side. On the other posts, he went to the left side. Okay, I ended on the right, and he ended on the left. Wait, okay. In this one, I ended on the left, and he stayed on the right-hand side. And I said to myself, hey, that may be a good thing, because that means that those weak structures, that left spine, that left shoulder, and that left neck are left, and they're over on the right side now. And now the neurology of that head will naturally turn back to the left, and I don't have to do anything except try to open it up. And all day long, the neurology will just help me out and just lift that head off the right side because it's free. Short-term relief, okay? We'll see the long-term stability of it. Maybe something has to shift where I have to go back on that other side or flip it around because the right side needs that support because of that right low hip, that right weight, okay? But right now, this guy's got a caving in on the left-hand side, the neurology of the head, which is never lies, okay? If it's right, something's left.
Were you going
Right.
to eye on the left side?
On the left-hand side, I went eye to well, yeah, you know, I do everything.
Okay. You're gonna say that.
I go eye to yeah. It's not eye to S. All right. Yes, I went eye to S.
That's the eye I meant.
I went with the bend point is C0,
Okay.
right? On the left
Yeah.
side.
Yeah.
So I went I to S up to C0, C1, and S to I. Okay.
Okay.
And that S to I, Matt Hunt is able to change that weight on that right side and also pull on that hip. That S to I move, pal.
Nice.
Okay. All right. So, you know, that I drew that little stick drawing, and you could see, you know, that's the way that thing can be setting up, that it needs that left support right now. You know, that right weight is from the hip and the leg over there, but that left is in failure, and it's falling down on that left-hand side, and his neck is compensating for it. Okay? So, food for thought. Okay? Once, you know, I had to look at it a different way. I mean, the algorithm wasn't taking care of it, you know? I mean, the algorithm is not life, okay? It's like it says, the algorithm is not animated. All right? So the algorithm looks at it as sticks and bricks, all right? Structure and function. And through our conversations about the biomechanics and everything that we talked to in the first one, and then what we've talked to all the way through is that we've learned that we may have to modulate some of these things when some of these guys are having trouble, okay? This is all with the caveat of one thing, okay? It's great to understand the game, all right? But more importantly, I don't care what the numbers say. I'll tell you, I'll take my piezoform over a number any day long, okay? So that ability to be able to feel that tension, attach onto that tension, move your path to bottom into that tension, and then go beyond it and release it is the only thing that is going to change that, not just poking around at it and tapping at it a few times and stimulating it. That is for sure. Okay. That doesn't mean that we don't help people. Okay. But if you want to go beyond that, and the place to be able to do that, and it doesn't happen often, okay, it hasn't happened for a while, is to have a class in my office. All right. So we've been doing these other classes, but because of this COVID thing, we did the class and then the webinar class, and now I'm doing a small class in my office. I think there's 10 seats left. Okay. And it's nice and cash, man. It's in my office. I think we're letting in 20 or 25 people, and that's it. So it'll be hands-on, and this conversation that we're having right now. Okay. So I hope you can join me. I'd love to be able to share this with you. Are there any questions for the evening?